One second. Yeah. So first questions in front of your screen. Uh, Patient had a history of pancreatic cancer on chemotherapy, then improved completely. Came to doctor concerning about the recurrence of cancer and history of many hospital visit. This patient has malingering, hypochondriasis, factitious disorder, conversion disorder, or something else. You can post your answer in the chat box, then we'll discuss one by one with the logic what you had and what's the literature. So those who are joining the first time, let me tell you this triad very important and interesting for me. Whenever you answer any questions, right, in any MCQs, right, first you need to know how you diagnose, how you investigate, and how you treat, right? So so most of the things are on website, but if it is not there, you need to little open up the book and try to get the answer. Three answer you must get for every MCQ. So for this MCQ we need three answers, right? So now right now they are asking the diagnosis, but I will ask you how you investigate, and I will ask you how you treat as well, because anything comes in the exam, right? So you can post your answer, right? So how Jabahar, what's the diagnosis, Dr. Jabahar?
Hypochondriasis, sir.
Hypochondriasis. So how do you differentiate hypochondriasis with the malingering, right? What
Malingering
are
the
the
patient.
differentiating point between this? We should know, right, whether they ask in the exam or not. So what is hypochondriasis? So hypochondriasis, what do you mean by hypochondriasis, and what do you mean by malingering? Tell me now. How, what's the presentation, or what's the presentation here? So what's the presentation in hypochondriasis?
Hypochondriasis patient has multiple doctor visit.
Multiple doctor visit. Excellent. Multiple doctor visit. Okay. And here what?
Mm.
Malingering what? How do they present? Malingering, how do they present?
They present with the different symptoms but refuses any test or
Sorry, can you make your mic bit closer, please? So there is a lot of echoes. Yes.
they present with the different symptoms
Different symptoms mean what symptom?
but
Different symptoms with what
the
symptoms? Something specific you remember malingering? If malingering come, right? What comes? What strikes to your mind? What strikes to your mind? Any comment, Dr. Minas? Any comment from your side? How you differentiate? Basically, we need to know all differentiation point. How you differentiate from A, B, C, D. There must be something specific in each and every MCQ. So how you gonna triage? How you gonna diagnose that? Okay, fine, sir. This is the malingering. This is hypochondriasis, factitious, conversion, OCD, whatever. Right. Any
So
comment,
can
Dr.
I, sir?
Minas? Yeah, yeah. Anybody, doctor. This is open forum. Anybody can interact. Yes, please.
Okay, so hypochondriasis, it's a psychiatric disorder. In this type of condition, the patient has intense fear of having serious life-threatening illness. But actually, they are not that much sick. So people with hypochondriasis, they misinterpret the normal bodily function as a sign of the illness. So
Okay,
they
fine.
go to the doctors often, I mean, repeatedly, whether they are
Fine.
saying that you are not that much ill or like that.
Fair enough. Is there any
And
new name for hypochondriasis? There is one new name for hypochondriasis now. In the books, it's
uh,
keep changing. Hypochondriasis is the older name. Any other new name, if you can remember, it's fine. If not, it's
so
fine.
it's like anxiety disorder, illness anxiety
Excellent.
disorder.
Excellent. Excellent. Illness anxiety disorder or anxiety illness disorder, both are the same thing. So, illness or anxiety illness disorder. Wonderful. That's the hypochondriasis. And what's the malingering? What do you understand by
So
malingering?
malingering is like a person who pretend to be ill to gain
Okay,
some
pretend to be ill.
benefit. Yes,
Excellent, wonderful. They are pretend to be ill and they want some benefit. That is why, say for example,
yes,
they
like
want the leave.
avoiding the school
They
or
want the
work.
leave. They
Yeah,
want the paid leave, right? They
yes.
want the paid leave. So they pretend to be ill, and there is a strong motive of some financial gain, right?
Yes, sir.
So this is malingering, right? Fair enough. Hypochondriasis. What is factitious disorder and what is the conversion disorder?
So factitious is like it's also a mental health condition, and in this case, someone pretends to be sick or I mean injured to gain the attention. In
Okay,
most of
so
the time, to get the attention.
so here to get the attention, right? Okay, fine. And what is the conversion disorder?
So conversion disorder, as far I remember, it's also a mental health case, and in this case, the physical symptoms that can be explained, uh, by the medical or neurological causes.
Okay, so they usually present with some neurological things, right?
It's a
And
functional
the
neurological symptom disorder. The conversion
right,
disorder is also called functional neurological symptom disorder, and
right.
it's also a mental health where the physical symptoms can be explained by the medical or neurological cause.
So here, whatever the neurological symptoms would be there, it is not matching with the anatomical or physical
Yes,
signs,
sir.
right? So
Yes,
patients
sir.
say I have a paraplegia, right? But
Yes.
if you examine the lower limb and
There
lift
will be
and
no
then reflex,
paraplegia.
right? So there is no paraplegia.
Yeah.
Signs are not matching with the complaint of the neurological
Yes,
symptom,
sir.
isn't it?
Most of the
Right?
time, the neurological signs will be like delusion, hallucination, or weakness, paralysis, then
Fair enough. Fair
incontinence,
enough.
tremor.
Fair enough. Fair enough. Fair enough. So those doctors who are, I mean, not very well aware of this disease, I strongly urge and request you go and read all the four things. Malingering, write down. This is homework. Every time we are giving homework, so you need to know three things: diagnosis, investigation, and treatment. Right? So, is there any specific investigation, Dr. Mowli, for all the disorder? Any scan, MRI, CT scan, blood test, some things,
Mm,
or any test, or it's all four clinical diagnosis by your
Sir,
means?
it's by the clinical diagnosis. I mean, there is
Okay,
no
fine.
like single test that can
Fine.
diagnose the test.
That can diagnose. Fair
Yeah.
enough. So clinical. So first of all, just only three homework, right? All four things are how do they present, right? You must know. Those who don't know, write down. This will 100% come in exam. You will remember me. Believe me. So I will sort out all the four things. How you diagnosed, right? Investigation, as we told, that it is a clinical symptoms and presentation mostly. There is no scan, no MRI, no MR angiogram, nothing, right? And what's the treatment? So this is the diagnosis, this is investigation and treatment. So what's the treatment of hypochondriasis, Dr. Mowli? What's the treatment? If the now the
Uh,
question is different, known case
yes.
of hypochondriasis comes to you, how you gonna manage this patient? So what's the treatment options?
So, it's normally we give the combined therapy like psychotherapy, medication, and lifestyle changes. In case of psychotherapy, we recommend the cognitive behavioral therapy, and
Okay,
in
great.
case of the medication, in we strongly prescribe the antidepressants like SSRI. And then
SSRI.
lifestyle change, we tell them to get physically active or
Wonderful. Wonderful. SSRI. What is the full form of SSRI?
so selective serotonin reuptake inhibitors.
Wonderful. So this is selective serotonin reuptake inhibitor. Second homework. First homework is to read all the four topics I'll give you and read the SSRI, specific SSRI. Alright. First of all, what is the indication of SSRI? This is homework. Indication of selective serotonin reuptake inhibitor, SSRI, and what drugs includes in SSRI, write down or take the picture, and commonest adverse event or side effects of SSRI. That's it. These are the absolute high yield questions in the exam. They won't ask you anything hi-fi. They ask around this only, but we need to know what exactly they ask so we can prepare accordingly, right? So now let's go to the nice, excellent chart here for you. I prepared this, right? So here hypochondriasis. Let's first start with the hypochondriasis, right? So as we seen hypochondriasis. So hypochondriasis is another name of hypochondriasis is illness, anxiety disorder. So they have anxiety of some underlying illness which is not there, right? So illness, anxiety disorder, fear of developing a disease, fear of developing disease, right? So example, they ask you in the example, patient has a cancer, now it's cured, but he is doing repeated investigation because he has a fear of developing disease. So cancer was in 2020, now this is 2024 and or close to 25. So last 5 years disease is cured, but every time he thinks something goes wrong, coughing, he thinks cancer. He has abdominal pain, he thinks cancer. He has backache, he thinks cancer. So he has a fear of developing the cancer. So what they ask, they give you in the history specific, repeated hospital visit, number one, repeated hospital visit, repeated investigation, repeated endoscopy. Every time everything is normal, endoscopy every time normal, every time cancer screening normal, every time they whatever the complaint they on investigation endoscopy normal. He has just the fear of developing the disease, though there is a no disease. So this is classical hypochondriasis or illness anxiety disorder. Illness anxiety disorder therapy means cognitive behavior therapy, and SSRI is the treatment. That's it. This is what you need to know. Another thing is a conversion disorder, as we seen. It's a psychological stress manifest into a physical symptoms. Psychological stress, stress at work, stress at home, stress of wife to the husband, blah blah. This is psychological stress manifest as a physical symptom. What physical symptom? Paraplegia, paraparesis, numbness, tingling, loss of vision. This is classical, comes in the scenario in the exam. So this is a due to some psychological stressor, they have a physical symptom. That's it. So this is the example. Right here, the treatment is mainly reassurance. You need to reduce the stress, counseling. That's it. Sorry, you don't need to give any kind of SSRIs or nothing, right? So it's little milder form, but it needs to be addressed well. Second thing, one is hypochondriasis, conversion. Third, malingering. Fake symptoms, the extremely important word is a fake symptoms. Fake symptoms means bogus symptoms, not similar to disease to fulfill some motive, right? So it's a absolutely fake symptoms, right? Not similar disease, right? So this is what again the counseling in malingering. And factitious disorder, want medical attention, and so there is a plethora of the symptoms similar to disease created. So they have long headache, backache, body ache, this that, they have long list of the plethora of the symptoms. Again, this is therapy. Factitious disorder, they wants the attention. This other way around, I can say they are the attention seeker, they wants to seek the attention, right? So this is the four things, and along with that I added two, somatization and body dysmorphic syndrome. What's that? You need to know. I mean, overall associated with some GI pain or sexual dysfunction, somatization, right? And body dysmorphic, preoccupied with imagined bodily defect. My nose is little deviated, my angle of mouth is deviated, I have something wrong on my face, I see scar on my face, right? It's a bodily image defect, though it is not there. Nasal septum is okay, but they think cosmetically when they see in the mirror, oh my nose is not well, oh my ear is not well, oh my this upper and lower lips are not symmetrical. It is body dysmorphic, right? Means body morphic means morphology. Body's morphology is not well. This is what they think. It is not there, but they think, right? So this is bodily dysmorphic, and this is a disorder where you need to give the SSRI. That's it. So this is what the thing is. So I mean, you need to know all the things, right? So far you have not gone through this all things. I strongly recommend you to go all the six conditions. I mean, you can take a pictures as well, or you can see the whole complete video end of the day, right? It would be there permanently on our website of YouTube channel. But if you want to take a picture, you can take it. It's very important, and all the condition under one roof, right? So it's easily mentioned here, right? So that's it. This is what the thing is. So this is illness anxiety disorder. In this disorder, formerly known as hypochondriasis, that patient is preoccupied with having or developing a serious illness despite having only mild symptoms or no symptoms. This patient become easily alarmed about their health. Something goes wrong, they are absolutely alarmed. That's it. So this is what the thing is. So I already told you. So answer here is hypochondriasis. You very well mentioned, Dr. Mowli. I'm glad you have a very nice concept clarity in your mind that what the disease is what, right? So it's very important to know. This is the topic usually we avoid. We don't want to look into it because we are confused many a times, right? So now
Yes,
you
sir.
go and read it. Yeah, you go and read it once again. You means everyone, right? So 100% one or two questions comes from all these four condition. Either they ask you conversion, malingering, factitious, or hypochondriasis. Second questions in front of your screen, maybe a very easy one liner, but it's you need to think little bit. Nissan fundoplication surgery is done for what disease or condition? Pancreatic cancer, gastric carcinoma, hiatus hernia, hypertrophic pyloric stenosis, peptic ulcer, or this kind of surgery can be done in any, all of the above. Take your time. These all are the recently asked questions in the exam. Huh? All I selected from the recently asked questions. Absolutely recently asked questions. Yes, Dr. Banish, what's your comment?
Sir, it's done for gastric carcinoma, Nison's fundoplication. It's a surgery which is it's used to correct gastroesophageal reflux disease GERD. It basically
Okay,
tightens the junction between the esophagus and the stomach so that acid reflux is prevented.
excellent. So your answer is gastric carcinoma. Hello.
Yes, sir.
Okay, fine. So gastric carcinoma is not the answer. Your explanation is absolutely fine, 100% correct, but it is not done for the gastric carcinoma.
Okay, sir.
Fine. Fair enough. Yes, Dr. Mowli, any
So
comment?
then,
Dr. Minas, I'm coming on that
Sir,
point. Let
it's
others to guide. Nisa
sir,
Lal.
it's hiatus hernia.
Okay, so you are hiatus hernia. Dr. Minas,
Hiatus
Dr.
hernia, sir.
Nisal, hiatus hernia. Wonderful. So what do you mean by hiatus hernia, Dr. Minas? What do you understand exactly by the hiatus hernia? We need to know. We don't need to mug up any answer. We need to know when we are talking about something. Hiatus hernia. So this is esophagus. This is a
So the
stomach,
art of
right? And this is a diaphragm. Say for this is diaphragm. This is how it comes, right? So this is diaphragm muscle, right? This is esophagus. This is gastric esophageal junctions. This very dark. This is G junctions above. This is esophagus. This is diaphragm. This is stomach, right? And this is GE junction where gastric and esophagus meets, it called as a G junction. So what exactly happens in hiatal hernia or hiatus hernia? Any type, any subtype, any type, anybody can banish, what is the hiatus hernia, how they present, or how the things goes in hiatus hernia, like
sir, in
umbilical hernia.
hiatus hernia,
And
there's a
how,
part of the stomach that pushes up through the diaphragm muscle, sir. The
right?
types are, sir, there's normal, esophagus and stomach. And in type 2, I think there is, it's called paraesophageal hiatus hernia. Then there is sliding, and then sliding and paraesophageal both. So I'm not
Wonderful, wonderful. No, no,
sliding
absolutely
and
right.
paraesophageal.
Absolutely.
Yes,
Absolutely correct. The only thing is not correct is the gastric carcinoma.
yes, sir.
Otherwise,
Yes,
you
sir.
explained very well. Anyway, this is what the learning is, right? So we get confused ourselves in the exam. So this is absolutely a nice diagram. I got it while researching the lecture, right? So this is what the thing is. So let me explain you very quickly. This is surgical questions commonly asked. So this is gastroesophageal junctions where the this esophagus and stomach meets. So this is exactly the G junction. This is diaphragm. So now see the pinkish part. So this is part which goes up stomach into the just above. So the stomach part is not above the diaphragm, right? So it goes above the diaphragm through the opening in the esophagus, right? So can you see here the stomach part goes into the esophagus? Can you recognize it? Yes or no? At least tell
Yes,
me
sir.
yes or no,
Yes, sir.
right? So this is red part is the stomach part which is in the esophagus. Here the red part, it's part of the stomach. So here sliding, so it slides, right? Like sliding the door, right? Above each other, sliding. This is sliding. This is paraesophageal, parallel to esophagus. Parallel to it can be, it goes here as well. So this is paraesophageal. This is mixed variety. This is sliding going up. This is paraesophageal. That is why they called as a mixed variety. And this is bit complex, right? So this is just the understanding how the hiatal hernia happens. That is what I want to explain you. So this is what the hiatal hernia various types, right? So this is what the hiatal hernia means, and what is the Nissan's fundoplication is, right? So as rightly told by Dr. Banis, absolutely fantastic the explanation by her in a single word, right? But those who don't know, it's a surgical procedure procedure in which the gastric fundus is completely 360-degree wrapped around the lower esophagus. So this is esophagus, stomach going, right? Say for example, paraesophageal, so 360-degree wrapping the esophagus, right? Wrapped around the lower esophagus to form a cuff, effectively narrowing of the distal esophageal and the gastroesophageal junction, prevent the reflux or gastric reflux disease, right? And it also prevents from the sliding. So what is the problem here? The esophagus, here the stomach. So part of the stomach is going into the esophagus. So if you tighten this lower end of the esophagus, it won't go inside. Is that clear? Yes or no?
Yes, sir.
Right, so it is clearly mentioned narrowing of the distal esophagus, right? Narrowing of the distal esophagus will help this fundal or part of the stomachs to go into the things, right? That's it. So this is what the thing is. Nisan fundoplication is done for the hiatal hernia, not for the gastric carcinoma. Dr. Manish, is that correct?
Yes, sir.
Wonderful. So don't now do the mistake in the exam. We don't need to miss any questions. We need 100% correct answer in the exam, right? So this is what simple but very important. So if you don't know the pathophysiology and treatment of the hiatal hernia, go and read it, right? Three things you need to read for hiatus hernia: how you diagnose the hiatal hernia, how you investigate, and how you treat the hiatus hernia. Let's move to the next very superficial basic lollipop questions. My questions are not always very hard and tricky. This is very important. Cortop sound. Cortop sounds heard in during BP measurement, congestive heart failure, infantile murmur, pulmonary hypertension, all of the above. So this is a sound. This is a sound heard
Yes, sir.
during
During
what?
BP measurement, sir.
Okay, let's see. So what other people are saying and what's that? We'll discuss one by one. It's all important, interesting MCQs today. So discussion brings more clarity rather than just the answer. So let's see. It is this answer or something else. We have lots of more than 30 doctors, but unfortunately we get 2 3 comment only. Yes, Dr. Vinodini, any comment you want to make, Dr. Vinodini? You can open up your mic. You can.
During BP measurement only we'll get this sounds.
So now tell me what is this Cortox sound? What exactly you understand by Cortox sound?
So these sounds
Describe
appear
me.
when the
No,
cuff
no. Let
press.
let let one minute, dear. 1 minute, dear. Sorry. Let her ask. I mean, I want to understand the logic. What exactly this sound? Okay, fine. Answer is correct. Those who had given the A answer during BP measurement, absolutely correct answer. Right. Those who have answered other than A, it's a wrong answer. All B, C, D, and E is all wrong answer. So now tell me, Dr. Vinodini, what you exactly understood by this sound, how you appreciate this sound, right? Where you heard this sound, right? How to know that this sound is a Cortox sound? Tell me.
Not able to explain, sorry sir.
It's fine, no problem. Not able to explain, excellent, wonderful, no problem, wonderful, no problem. So let me ask to the another doctors, right? Those who had given. Yes, Dr. Manjit Singh, what you understand by this sound? Manjit Singh, Sat Sri Akal.
Sir, during diastolic, when we are deflating the cough, then one sound is coming. But how to explain, that's a little bit difficult.
Yeah, it's a very important, interesting. So you go
But
and read it,
during
but sir.
deflation of the cough,
Okay, so if I can ask you, I mean, questions more specifically, it is heard
hmm,
during systole, it is heard during diastole, it hurts during what phase of the blood pressure measurement? This is
during
important, na?
systole,
So when you deflating, it is diastole, na? Usually, I mean,
Both
or when the blood
systole
pressure,
and diastole.
systole and diastole. So when it start and when it stops, then Cortop sound starts listening when and
This is
stops
the
listening when.
Starts at systole and ends by diastole.
Okay, wonderful. So that could be a specific answer. Starts at the systole. So probably the intensity will go duck, 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 and then go down. Isn't it? Yes or no? So when you cup the things, right? When you cup 120, 130, 150, 170, at one stage it stops. Then you release, then systolic will hurt. Then again the voice is going, right? So once the appear first sound after, right, and going the sound is a diastole. So quartok sound is very, very important. So let's see what the literature is saying. So quartok sound definition: sound heard when the auscultating over the brachial artery. So we put a stethoscope in the cubital fossa. That is the brachial artery, right? When we are measuring with the stetho. Otherwise, in a digital, probably you get systole, diastole, right? So definition of sound heard when auscultating over the arteries during the sphygmomanometer. Origin: turbulent flow through a brachial artery. So when brachial artery we are inflating, deflating, there is a obstruction and relieving of the brachial artery, so sound create, and that is partially compressed by the inflated arm cuff of the sphygmomanometer. Interpretation: when deflating the cuff, the pressure at which the quarto sound appears marks systolic blood pressure, and pressure at which the quarto sound disappear is called as the diastolic pressure. That's it. So it's a simple, it's like in a word form, but when you apply the cuff, right, and when the first sounds coming up, it is systole, and then intensity go and down. So when you have a sound first, it is systolic. When the absolute gone sound, it's a diastole, right? So interpretation is what? When deflating the cuff from 160, 150, 140, 130, right, where the cortex sound appears first time, it's called as a systolic, and pressure at which the sounds disappear makes the
Disappear.
diastolic blood pressure. That's it. So this is what the thing is. If you have not appreciated well, again try to check the BP by you, by not by the nurse. So check 1 or 2 times blood pressure to patients in your OPD today, tomorrow. So then try to appreciate first sound systole, second diastole. So this sound is called the the uh, the cortex sound. So this looks easy. This is similar word, right? What is a Korsakoff syndrome? Korsakoff syndrome. Don't read this, huh? Genuinely.
Vitamin B2.
Korsakoff syndrome. Korsakoff syndrome, because this is little cortex sound, and
Welcome.
this is the syndrome called as a Korsakoff syndrome. So anyone knows what is Korsakoff syndrome? Similar word,
So Wernicke's
important.
Korsakoff
Sir,
syndrome
Korsakoff
over
syndrome.
Yeah, yeah.
because of,
You speak, no
because
problem.
of alcohol, sir, it happens. Deficiency of vitamin thiamine.
Vitamin thiamine. Thiamine is a which number of vitamin? B1
B,
to B12.
Sir, B1.
B1.
One.
B1.
Yes,
Wonderful.
sir.
What is a
So
B2?
Korsakoff is a neurological disorder, sir, that affects our memory due to the deficiency of thiamine.
Okay, wonderful. So this is what second thing. Any other comment for this syndrome? What's the treatment then? If the
The
same patient
thiamine
comes to you,
supplementation.
thiamine supplementation.
Yes,
Okay,
sir.
thiamine.
Nutrition and hydration, IV fluids, nutritional
Fine.
support.
Okay.
समझ गया मैं. Got it. So is
That's
there any injections available in the market which contains thiamine?
Sir,
Can you name the
intravenous
things?
vitamin B1.
B1. So separate intravenous vitamin B1 is available. Separate vitamin, thiamine only.
So there's a thiamine injection, just 2 ml, which
Thiamine
is given.
injection is available. Only B1 available. I'm just trying to understand. No? Don't take it otherwise.
Yes, sir. Thiamine injection is available.
It's available. Wonderful. Fine. So anyone can post the vial of the thiamine injections, just other people's understanding,
Thiamine injection
right?
also.
Yeah. So, and what's the strength? What is the dose?
Some shata.
What is the
So
dose, Dr. Banish? What is the
2
dose?
ml, 2 ml.
No, no. Never, never. This is my tips of 20 plus years of clinical experience. If you want to be a good doctor, don't put it in the ml. Always remember in mg. Never, because 2 ml could be 40 milligram.
Yes.
Some company making 2 ml as a 80 milligram. Some company
Okay.
making 2 ml as a 10 milligram. You understand? So ml
Okay,
is
so
always not good idea, honestly speaking. Milligram is important.
so in sir, recommended daily allowance, or are you asking me for beriberi or some other
Yes.
disease?
So if the Korsakoff syndrome patient comes to you, right? How much dose you give to the patients, those who have a syndromes or neurological symptoms or Wernicke's encephalopathy, where you also give B1 or thiamine, right? So you go and find out, right? It's important things, very
500
important.
milligram
Right. So you give me the
IV.
literature, official literature, send me, right?
Okay,
Just
so
do some exercise 5-10 minutes after my class and do. So Wernicke's encephalopathy, it's not related with this, but the word are similar. That is why I put one
mm-hmm.
slide. Kortok and Korsakoff syndrome, right? So this is extremely important. I'm just muting the sound of everyone because I got a lot of background noise. You can unmute if you want to interact. Okay, wonderful. So Wernicke's encephalopathy is acute but fortunately reversible condition caused by severe thiamine B1 deficiency, often due to chronic heavy alcohol use. Inadequate intake and impaired absorption and increased excretion of thiamine can also cause Wernicke's encephalopathy. And the classical triad, this is classical triad. You must remember, they ask the Wernicke's encephalopathy as well as how you diagnose. So confusion number one, oculomotor dysfunction and gait ataxia. This is triad. So if this thing comes in the exam, in alcoholic patient, it is none other than Wernicke's encephalopathy, right? So all confusion is there. Obviously, oculomotor dysfunctions and gait ataxia, right, is seen about third of the patients. Chronic thiamine deficiency, especially in patient with alcohol use disorder, frequently progresses to Korsakoff syndrome, which is characterized by irreversible personality changes. So now what the difference begins? Wernicke's is the initial stage of chronic alcohol abuse. It's fortunately reversible, but it goes unnoticed, untreated. Advanced case will convert into the Korsakoff syndrome, and this Korsakoff syndrome is irreversible personality changes, antegrade and retrograde amnesia, and confabulation. The diagnosis of both are is clinical, but laboratory tests confirming the thiamine deficiency and brain imaging may be considered in ambiguous cases. Ambiguous cases is doubtful cases. So a current Wernicke's encephalopathy is an emergency and required immediate high dose IV thiamine. Your homework, Dr. Banis, is what do you mean by high dose IV thiamine, followed by long term thiamine supplementation. So that's
Okay.
all for this two, Wernicke's encephalopathy and Korsakoff syndrome related with Kortok sound. So I thought let me cross check your things. Looks like and pronounce same, like what's the difference? So this is the difference. So we covered many questions in one question. So let's just jump to the another questions, which is very important clinically. Which of the following is not true for heparin induced thrombocytopenia? HIT type 1 is non-immune and type 2 is immune. HIT means heparin induced thrombocytopenia type 2 can cause thrombosis. 3. UFH means unfractionated heparin can cause low platelet but not LMWH, right? And observation is the treatment in HIT type 2. All of the above statements are true. So what they are asking, which of the following is not true? Is not true, right? So everything is true, one is not true, or probably all of the above are true. So you decide what is true, what is wrong. Take your time. We'll discuss in detail. These questions very important. Those who are working in ICU, heparin is everyday's job. You do cath flush, intra cath flush, right, to prevent the block line in central line. You push, right, 1 in 10 dilution heparin, right, into the central line or subclavian line or peripheral PICC line, PIC line, right. You just simply inject small volume of heparin, and heparin is a day-to-day job in ICU almost everywhere across the globe. So they are asking heparin induced thrombocytopenia. What's the truth? What's the wrong? Take your time. Yes, Benis. What do you think? C is the answer?
Sir, yes, I think C.
Okay. So let me ask you one question only. Right? What does it mean? What I interpret from the answer C, that unfractionated heparin can cause low platelet or thrombocytopenia, but LMWH does not cause, right? It is right or wrong sentence?
So I'm not sure, sir, about this question.
So let me tell you. You read one by one. Na? Once I explain you, everything is crystal clear. But let me tell everyone, heparin induced thrombocytopenia means any form. Fix in your head. Any form of heparin can cause it. Any form of heparin, whether it is two form unfractionated heparin or it is low molecular weight heparin. Is that clear? Yes or no? Wherever the heparin word comes, it can cause thrombocytopenia. Dr. Banish, are you understand? You understand? Yes or
Yes,
no?
sir. Yes, sir.
So means this is your statement is wrong, right? What they are saying, unfractionated heparin can cause low platelet but not the LMWH. So LMWH can cause low platelet because H means heparin H means heparin. So any form of heparin can cause thrombocytopenia, whether it is unfractionated, low molecular, high molecular, whatever molecular. Heparin means thrombocytopenia. So your answer is wrong. Yes, anyone now?
Sir, it's D.
Okay, so answer is D. That means A, B, and C is correct, right? By your sense?
Yes, sir.
Okay, so observation is the treatment in heparin induced type 2.
Yes,
That
sir.
is not correct, right? Observation is not the treatment, right? That is
No,
the
sir.
correct answer. So what is the treatment then?
So
If
it's
you have a heparin induced
anticoagulation.
thrombosis, so now excellent, anticoagulation. So already there is a thrombocytopenia, low platelet, and then on top of that you want to give anticoagulant. Why? Because already there is a low platelet, you are giving antiplatelet, you are making more things worse. Comment. Because say for example you had given the heparin, right? Just understanding,
Sir,
right? Patient
yes, sir.
pa-
Sir,
one
you
minute,
will.
patient admitted in ICU, patient's platelet count is 200,000 or 2 lakhs platelet count on admission. After 3-4 days the platelet counts become just 50,000 after giving the platelet. So there is a low platelet, now patient has a low platelet, and on top of that you are saying you want to give anticoagulant. I'm trying to confuse you as well, but you stick to your answer. I'm trying to make you understand. Now you are saying the treatment is anticoagulation. So low platelet and anticoagulation, can't it be extremely increase the risk of bleeding in patient? Yes or no? Yes or no?
Yes, sir.
Okay, so now tell me what is the logic of giving? Your answer is 100% correct. Give anticoagulant. But I want to know why you want to give
Okay.
anticoagulant. What's the reason?
So in heparin-induced thrombocytopenia, first we will stop the heparin. We
Yeah,
will do the
wonderful.
flushes. Then
Right.
we will do the
So,
catheter.
so stop heparin in any form, right? That
Yeah.
is the first and foremost treatment. Okay, wonderful.
Yes, sir.
Right, you did it. Now what else the next you want to do? You stop all form, flush, everything, you stopped it. Now
Yes,
what
sir.
you want to
Then
do?
we will switch to another anticoagulant, alternative anticoagulant.
What is the alternative anticoagulant means what? Tell me
So,
the name of alternative anticoagulant.
so
Anyone,
it,
huh? Anyone can comment.
sir, argatroban or fondaparinux.
So what is fondaparinux? It is low molecular or UFWH?
No, sir,
Fondapari.
it's factor 10A inhibitor, no?
Okay. No, I'm just trying to understand from fondaparinux. Right. Okay. So fondaparinux is what basically?
So it's a clotting factor inhibitor, factor 10A inhibitor.
Okay. Factor 10A inhibitor by you. Fondaparinux is factor 10A inhibitor. Okay. Fine. What else?
Sir, enoxaparin.
Enoxaparin, which inhibits which factor? You need to tell me. I taught you the last time the complete clotting cascade. Anyone? Dennis? Anyone expert in the comment working in ICU probably have little better clarity. Dr. Nisa Lal, Dr. Minas.
Bilirubin
Sir,
is
enoxaparin
a
is
thrombin
also low
inhibitor.
molecular weight heparin.
Which heparins? I wrote one name that is a pendoxaparin. That is perfect. It is a factor 10A inhibitor. It's correct answer. What else?
No,
Only
sir,
one drug?
sir, no, there was one.
Rivorabaxan. Excellent. Another name, Rivorabaxan. Yes, that's correct answer. What
Bilirubin.
else?
Apixaban.
Bilirudin.
Sir,
Apixaban. Correct
ergotroban.
answer.
Apixaban.
Ergotroban.
Ergatroban. Very good. Wonderful. Now
Rapid
see lots of
answer.
comes picture. So this is what this called as a. Can I give the name to this all drug? Direct thrombin inhibitor.
NOAC
Hello.
or DOAC?
Doak.
Direct thrombin inhibitor. Great. Wonderful. So now let's understand what is type 1 and type 2. Excellent clarity I'll give you. Don't worry. Then you ask me the question. This is tremendous, excellent slide. Take a picture. or later on review it once again, this my slide. So heparin induced type 1 and type 2. There are two types. Heparin induced type 1 and type 2. What is the basic difference between type 1 and type 2? Type 1 is non-immunes. Just remember, if you listen me carefully, absolutely all complete clarity. Non-immune, this is immune mediated, immune mediated. So this is the biggest difference, non-immune and immune mediated. Right here, type 1, 10 to 30%, right, of thrombocytopenia who are treated with unfractionated heparin. So if you give any patient in ICU unfractionated heparin, there are 10 to 30% chances they develop type 1, which type 1 is, you can say, also non-critical. Non-critical, non-dangerous. This is critical, this is dangerous. Non-immune, immune mediated. 10 to 30% of the patient with unfractionated heparin develop type 1, and here see type 2, only 1 to 5% unfractionated heparin. But both can develop, Dr. Banish, both can develop, right? Unfractionated as well as low molecular weight heparin. Less common, but it can happen. Dr. Banish, is that clear to you? Yes or
Yes,
no?
sir. Yes, sir.
Right? So unfractionated heparin and fractionated heparin both can cause thrombocytopenia, but the chances is more with unfractionated than fractionated. Right? Number one. Number three, how fast the platelet goes down. This is time frame is usually 1 to 4 days of initial unfractionated. Today is the today is the 8th of the December. You patient admitted in ICU on 8th, right? Or 9th or 10th, they develop low platelet. Usually after 1 to 4 days, not within one. Today started, morning started, evening low platelet doesn't work in that way, right? Usually in 1 to 4 days. So 8 December to 12 December, any time in between they develop the low platelet. So usually in first 1 to 4 days, and this is usually late. Why? Because it's immune mediated. They need some kind of antibodies to develop against heparin platelet factor, right? And then they develop this antibody will kills the platelet, right? And they make the thrombosis pathogenesis as well. So this usually start after 4 to 16 days. So how do you recognize in your ICU, right? So your medical officer says, sir, platelet, when patients admitted, platelet counts were 200,000 or 2 lakhs. Now it is 1 lakh. What happens? What is this? So what you need to do? Forget about everything. Just look at the days. Within 1 to 4 days develop, it is grade 1 or type 1 heparin. On 5, 6, 7, 8, 9, 10, 11 days up to 2 weeks, anytime in between, it is a immune mediated. So this is 2. Non-immune mediated or type 1 is usually platelet counts want, usually they don't go below 100,000 from the baseline, So initially it is a 200,000, right? In 1 to 4 days it goes up to 140, 150. Even with normal platelet you can see it is a heparin induced thrombocytopenia. Platelet reduced means heparin induced thrombocytopenia. It does not require that it goes below 10,000, then it is heparin induced thrombocytopenia. Even though if it is within the normal limit, it is a heparin induced thrombocytopenia. So extremely important, you need to monitor while patient is on heparin, right? But usually the this is the our observation in last many years being hematologist as well, right? They won't usually go below 100,000, and they can go up to any extent. One of the patients we recently treated reached up to 20,000 in my patients last month. Same case we treated, type 2, right? So 200,000. So the extremities is low. They go up to the bottom. They go down. So they started with the 200,000 or 2 lakhs platelet count, but with on day 5 or day 6 they have just 20,000. 90% of the platelet reduced from 2 lakhs to 20,000. Extremes of numbers can go down. Here type 1 no antibody, as I told you. Why no antibody? Because it is non-immune. There is no immune reaction, so no antibody, right? And biggest thing is no immune reaction, so no thrombosis. Here both, yes. It is antibody related, yes. Why? Because it is immune mediated, so some kind of antibodies develop and they makes the thrombosis. So this is the things where patient die. They will not die usually in heparin induced thrombocytopenia because of bleeding. They die because of thrombosis, let me tell you. Very important. And to prevent this thrombosis, Dr. Mowley, you are giving anticoagulant. Yes or no? Dr. Mowley, yes or no?
Yes, sir.
So there are two pathology in heparin induced thrombocytopenia: low platelet plus thrombosis. That's it. Here only just low platelet, no thrombosis. See here, no thrombosis. So here low platelet plus thrombosis, and to prevent this thrombosis or treat this, you need to give anticoagulant. Management here, it is non-dangerous, non-critical, just observe, stop the heparin. Only simple treatment. Stop heparin, automatically it will come up because there is no antibody destructing the platelet and doing the thrombosis. So just observe, stop it, monitor. That's it. And here your job is not finished just by discontinuing the heparin, but you need to treat with DTI. DTI. What is DTI? Direct thrombin inhibitor. That is DTI, direct thrombin inhibitor. That's it. So this is what the treatment is, direct thrombin inhibitor. Right? This is self-limited, means observe by its own, it will go away. No need any treatment. And here death. Here death. See, here no treatment, absolutely fine. Here death can happen. Arterial and venous thrombosis and potential are the potential complication, not the bleeding, not the thrombocytopenia. What the death complication is, thrombosis either in arteries or vein, and to avoid this or to treat this, you need to add anticoagulation. And this anticoagulation you rightly explained. These are the new excellent chart and slide I got it for you guys. So just concentrate on it. I'll make everybody's mute because I got a lot of background noise. So all mute now. So direct thrombin inhibitor, shortly known as a DTI. DTI is a direct thrombin inhibitor. DTI, direct thrombin inhibitor. These are the drug. These are the ergotroban, bilirubin, this dabigatran, blah blah. Right. So there are lots of drugs. So what they exactly cause, they, right? So you can't use the this other direct thrombin inhibitor. You can't use any form of heparin, no heparin in any form. Treatment, main treatment is no heparin, whether unfractionated heparin you cannot use, low molecular weight heparin you cannot use. Then how you anticoagulate this patient without heparin? Direct thrombin inhibitor. These are the drug of choice. And antidote, if you have a toxicity of direct thrombin inhibitor, right? PCC means prothrombin complex concentrate, and antifibrinolytic like tranexamic acid is the drug of choice. That's it. So this is what the thing about the thrombocytopenia of heparin induced. Is that clear to everyone? Any questions to the house? I tried my level best to make it more simplified for you guys, but still if you have questions, I would be glad to answer you. Any questions, Banish?
No, sir.
Wonderful. It's all clear,
Yes, sir.
right? Wonderful. Wonderful. So now let's go to the questions. Then now we have a complete clarity now for the heparin-induced thrombocytopenia so far, right? So heparin type 1, right? Heparin-induced thrombocytopenia. Sorry, where is my pen? Yeah. Heparin-induced thrombocytopenia 1 is a non-immune and type 2 is immune. This is right or wrong?
Right.
This sentence is right or wrong? I taught you everything,
Right,
right?
sir.
Right? Because type 1 is non-immune, non-dangerous. This is immune, dangerous. That's it. Here no thrombosis. Here yes, thrombosis is there. So type 1 is non-immune. This is immune. Type 2 can cause thrombosis. Yes or wrong?
Yes,
No.
right,
It's
Right, right.
right.
Unfractionated heparin can cause low platelet, but not the low molecular weight. It is right or wrong?
Is it true? Wrong, wrong.
Wrong. That can goes.
Wrong. Observation is a treatment of type 2. Observation is treatment
No,
for type 2, right or
No,
wrong?
sir. No, sir.
wrong.
It's
Here are the two
right.
There
wrong.
must be
So
DTA.
here, yeah, so here we need little modification. Unfractionated heparin and low molecular weight heparin can cause low platelet. This should be the answer. Then it is right. Am I right or wrong?
Yes,
Yes,
Both
yes.
sir.
can cause,
Wrong.
right? So observation is never a treatment. What my take home message is, observation is never a the treatment in heparin-induced thrombocytopenia. They die because of thrombosis, mainly venous thrombosis, right, or arterial thrombosis. I've seen patients with the cardiac thrombosis, cerebrovascular thrombosis, coronary thrombosis. So they die because of thrombosis, not because of hemorrhage or not because of low platelet in HIT. So hopefully I'm clear from my side. So I think I try my level best. This is the schematic presentation. right? Various type, where is the various ischemia happens in this. So I'll share this slide, but everything I explained you properly in detail. So let's jump to the next questions. Which of the following covers MRSA? Which of the following covers MRSA? What do you mean by MRSA? Methicillin resistant Staphylococcus aureus, recently asked question in hard exam. Septazolin, cefuroxime, septazidime, cefepime, and septaroline. Take your own time. Take your time. Don't be in hurry. At least you have 30 seconds for each question in exam. 30 to 50 seconds. Take your time, but try to get a correct answer. Only just two answers. We are almost, I can see 35, 40 doctors now in the class. But unfortunately, answer is two. Yes, Walter. Any comment, Dr. Walter? Dr. Antara, any comment? Dr. Ravi? This is absolutely high yield questions. You must know it. You can't skip it. Yes, Dr. Maria, Glory, any comment?
Fourth or fifth generation. So
Sorry?
fourth or fifth generation. Fourth and fifth. Because gram positive coverage is more in fourth.
Fair enough. So select one answer. A, B, C, D, or E. Post it in the chat box so I can understand your concept. And I can discuss with you as well, obviously. Yes, Dr. Nasrin, any comment on this, Dr. Nasrin?
Sir, cefazolin is given before surgery.
That's fine. I mean, we are not now, just sorry to little interpret the questions for you. This is not about surgery or non-surgery or anything. What's the question? Which of the following covers MRSA? And MRSA stands for methicillin resistant Staphylococcus aureus. So you need to post one answer that, okay, fine, this is the one. So A, B, C, D, or E. Now you tell me. You think over it. Yes, Dr. Maria, I want to listen from you. Open up your mic.
Yes. So
Yes, what?
ceftaroline.
Ceftaroline. Okay, fine. So let me ask you questions. First
Yes,
of all, you know the group of cephalosporin, yes or no, first of all?
yes, sir.
Okay, how many groups of cephalosporin? How many groups of or how many generation, I can say? How
So
many generation?
total 5 generations, sir.
1, 2, 3, 4, and 5. Why
Yes.
why they have a need to make this 5 generation of cephalosporin? Why they can't give only 1 generation of cephalosporin? Why there 5 generation? What's the
So,
logic?
sir, to cover maximum organisms or the resistant ones which gets
Wonderful.
emerging, so to
Excellent.
treat them.
Excellent. Excellent answer. Very happy. Maximum organism coverage. So it is like I can say in mobile language 1G,
Yes, sir,
2G,
exactly.
3G, 4G, and 5G. Is that correct? Why this G? Fifth generation, broadband, Reliance, blah, blah. More speed, more data, more downloading, more speed, more better, right? So same way,
Right, sir.
considered in that same way. So this, right. Now tell me, what is any one name of each drug? One name of each drug, Maria.
So
You
first
have to answer all
generation.
the question. Yeah.
Yes, sir. So first generation, it includes cefazolin and cefalexin.
Okay, so cefazolin. Okay, only I need one name only, right? Being a
Okay.
clinician, you should know. Second generation?
Second generation, it's cefuroxime.
Cefuroxime, second generation. Third generation?
Third is ceftriaxone.
Ceftriaxone. Fourth generation?
Fourth, cefepime.
Cefepime. Fifth generation?
Ceftaroline.
Ceftaroline.
Wonderful. Excellent. Excellent, really excellent, wonderful. This is so we get a concept why the generations are there. Number one, what are the generation? What are the single name? I mean, you are clinician when right. So this is the name. Now comes to the organism. Organism. If I can say, which generation covers MRSA? First, second, third, or fourth? If you say yes, I will take yes or no cross. First generation covers?
No, sir.
No. You give your answer. Huh? I'm just posting your answer. Second generation covers MRSA.
No, sir.
Third, fourth,
So, fifth, it
only fifth.
covers.
So third and fourth. So you mean to say only fifth generation septaroline, that is the E answer, septaroline only covers
Yes,
the MRSA. Is that correct answer? Yes or no?
yes, sir.
Yes.
Yes. So
Specify
for everyone,
Specify
for
also can
everyone,
cover. Fourth generation
yeah,
also can
you are
cover.
you are right, sir. You are right. But as per this MCQ, I am taking yes answer only among this list which covers MRSA. So answer is septaroline. So here she is absolutely right. A right 1 2 3 4. This 1 2 3 4 will not cover, only septaroline cover. Let me come to the pseudomonas. If I ask you, I change the question, pseudomonas, which cephalosporin group 1 to 5, same question, same option, right? Instead of MRSA, if I pushed pseudomonas, which of the same option? What's the answer?
Fourth generation. Fourth
Cephalosporin.
generation.
Sorry?
Fourth
Third.
So third and fourth.
Third.
Third and fourth. So one answer is third and fourth. Third as well as fourth. Okay, fine, fair enough. Any other answer? Someone is saying only fourth. Any other answer?
Sir,
My answer, yes, sorry. Go
third
ahead.
and fourth, sir, third and fourth.
Third and fourth. Okay, fine, fair enough. Any comment, random comment, whatever in your clinic you learn, you understand. Whenever you had some bad patients or ICU patients, septicemia patient, sick DIC patient, in your ICU you did a blood culture, right? Or you did a sputum culture, and in culture it shows it is a, I mean, Pseudomonas aeruginosa found in your blood culture, right? What antibiotic you prefers for this patient? That is what I'm trying to explain. And if you have the same list, right, what you prefer to give in this patient, first generation you give, or second or third or fourth or fifth, or what?
Fourth generations.
Third.
Fourth.
Third,
Fourth.
fourth, third and fourth. So maximum answer is third and fourth. Okay, fine, we'll see the literature. I have excellent chart for you, don't worry.
Fourth generation.
I will not go without any literature. If I change my answer, E. coli, now what's the answer? E. coli, same option, A to E, same option.
The first generation.
First generation means second, third, fourth, fifth is not working in that. Probably you never think in that way that this could be the question comes in exam, isn't it?
Sir, E.
They are
coli can be resistant to third generation. So maybe not third generation. Other than that, it can be
okay,
used.
fine, fair enough. We'll see. Another question. In one question, there are 20 questions. Another question. Gram positive and gram negative coverage, if we are talking about, what this 1 to 5, which covers more gram positive, which covers more gram negative?
The 5 covers more gram positive. 4 and 5 cover more gram positive.
Gram positive. Okay. Let's see what other expert says.
As it increases, the generation increases, gram positive coverage increases.
Fine, fair enough. Let's see. Anyone? Yes, Dr. Banish. Any comment, Dr.
The
Banish?
first generation covers gram positive, and
Second, third,
succeeding
fourth, fifth.
generations cover against gram positive strains.
Yeah, so we are not going much in streptococcus, staphylococcus, right? Pneumococcus, all coccus is gram positive.
Sir,
So what I'm trying to.
So first generation is for gram positive. It's
Mm.
effective in that. And then in second, third, and fourth, in second and third, they are for gram negative more, and fourth is for both positive and negative.
And fifth?
And fifth is
Save 200 rupees on Google Pay for business.
So fifth is for also both the gram positive and negative.
Fine. So everyone's homework. I have long list of questions for this. Only one question. What about Proteus? What's about Klebsiella? What about Pseudomonas? What about E. coli? What about influenza? What covers what? So you need to know. I have an excellent chart for you guys. So don't get scared. Right? It's lots of question. How to find out, sir? From which book we have to find out? Everything is there in the book. Just we are not concentrating and reading well. We are just mugging up the answer. So I don't want anyone to mug up the answer, and that is why I'm here and trying to open up your mind and neurons that how you supposed to prepare from today onward, right? That is more important than just mugging up the answer. Let me ask you the list, right? So say for example here the septarolin is the answer. So let me ask the another way, which drugs covers the MRSA now? These all questions in exam different way. So those who don't know about any generation of cephalosporin, humble request, right? You go and read this all cephalosporin group of the drugs, right? It is very well given in the Master the Board as well as many books. It is given absolutely well. So don't hesitate to open up the book, open up, read it well, and try to understand what covers what, so that will really helps you to understand better. Next question. What's the next question? Next question is, I want to know the drug list which covers MRSA. Say for example one is septarolin. Okay, so I included one drug is a septarolin.
So vancomycin.
So vancomycin. What other drug?
Trimethoprim. Trimethoprim.
One minute. Linazolid. Okay, one by one. Linazolid, vancomycin, linazolid, septarolin. Any other drugs which you can remember which covers MRSA?
Clindamycin.
Clindamycin,
Doxycycline.
doxycycline,
Trimethoprim. Sulfamethoxazole.
sulfamethoxazole, TMP, trimethoprim. What else?
Sir,
If I
daptomycin.
Minocycline, sir.
Sir,
daptomycin,
daptomycin.
excellent. Minocycline,
Quinpristine.
colistin. How many names come? See, you are all brilliant. See how many? We are struggling for one answer. You given 10 answers. Wonderful.
Doxorubicin, sir.
Yes.
Doxorubicin.
Which, sir? Okay. What's the exact name you told? Sorry, your voice is little breaking to me.
Doxorubicin,
Which-
sir. He was saying doxorubicin.
Doxorubicin. Okay. Fine, fair enough. Ticoplanin. Ticoplanin. Don't do the Google, huh? Sorry. Yeah. So, if I can ask you another question, if you have MRSA, amongst whole the list, which drug you want to use first? If your patient is in ICU,
Vancomycin.
ICU and blood culture shows MRSA, which is the first drug? So vancomycin is the first.
Vancomycin.
Yes, absolutely correct. If I can say vancomycin is resistant,
Linezolid.
Linazolid.
second is a linazolid. If both are resistant, which drug you want to use
So
as a third drug?
clindamycin.
Sir, daptomycin, sir.
Daptomycin. So someone is saying daptomycin. Okay, fine. So fair enough. I'm extremely happy. Overall, all the answers are correct. Now I'll take you to the journey to the literature of this all cephalosporin in a simpler way, in a more easily understandable way. So all your queries, confusions is absolutely gone now in next 1 minute. I have excellent chart prepared for you guys. So if you see it, you can understand the things quite well. So let's move to that chart. This is the chart. This is the chart, right? So this is what the cephalosporin, this is what the cephalosporin, right? So what this cephalosporin means. So this is first generation and this is fifth generation. Just name oral cephalaxin just for your understanding. IM and IV cefazolin, absolutely perfect. Second generation oral cefaclor and cefuroxime, IV cefuroxime, cefoxitin and cefotitan. This is IV. You don't need to remember all the things, but at least remember one name because you are clinician. Sometimes you have to use it, right? So At least you should know one from one generation. Oral and IV, oral and IV. That's it. Third generation cefepime, cefixime, and doctor also told ceftriaxone. It's good enough. Fourth generation's IV cefepime, and this is mainly for your just quick pseudomonas. Ceftaroline MRSA. Is that clear? Yes or no? At least tell me yes or no. I'll come to
Yes,
the
sir.
Yes.
organism now, right? So this is what the thing is. You need to remember this, right? Now let's move to the extremely important part. MRSA, right? So again MRSA, right? So again MRSA. So if you can see here MRSA, right? First line treatment. MRSA stands for methicillin resistant Staphylococcus aureus, right? First line treatment is vancomycin, right? And what is this? Vancomycin resistant, then linezolid. That's it. If you remember this, I would be glad and happy. That's fine. Another thing, first line, vancomycin, vancomycin resistant, then linezolid, right? Here, vancomycin, then you can use linezolid, you can use daptomycin, you can use TG-cycline, you can use ceftaroline, that is the fifth generation cephalosporin. Yes. Then you can use the doxycycline, you can use the dalfopristin. This is new drug anyway, but that's fine. You have another familiar names, right? And these are the another things, right? So here vancomycin absolutely resistant. These are the options. Or vancomycin possibly also this potential resistant to this linezolid, and these are the another drug which also you can use TG-cycline and daptomycin, right? So that's it. This is what the drug cascade of these things. And last but not this, extremely, I love this chart. If you remember this, you can answer any question in exam and you can treat your patients well in your OPD, IPD both, right? So that is what the thing is active. So this is first generation. This is second generation, third generation. It was very long slide, so I split it into the two. Otherwise, it was one slide, but I cannot cover up in one PowerPoint presentation. So this is continuation with this, right? So first slide is this. What is 1, 2, 3, 4, 5? Second slide is this, and third slide is this. So this is first, second, third, fourth, fifth. That's it. So here activity against gram positive. See now the beauty starts here, right? Activity against gram positive. So what is first? First, highly active, less active than first generation, least active amongst all cephalosporin, least active, least. So what does it take home message when you have gram positive? Never ever use third generation. Second, this is little less likely. This is the highly active. So what you can use highly active, gram positive, right? It comes in the blood culture. So either you use highly active first generation, highly active fourth, and highly active five. Another rule of the antibiotic, never start from the highest, start from the lowest, start from first generation. If doesn't work, fourth generation. If doesn't work, fifth generation. If you have gram positive bacteria and they are gram positive bacteria found in the blood culture, don't start with the fifth generation. If not work, then fourth generation, then one. Absolutely wrong. Start with first generation. If no work, fourth generation. If no work, five generation, to avoid the resistance. Is that clear? Yes or no? Is that clear? Yes or no? This is basic
Yes.
principle of any antibiotic.
Yes, sir.
In this, forget about cephalosporin. Any antibiotic, start with the lower, escalate up to the higher. That's it. Is that clear to everyone? Yes or no? Right? So this is about the gram positive. Now see the gram negative. So the gram negative, right? So they are shortly called as a PEK, Proteus, E. coli, and Klebsiella. PEK, Proteus, E. coli, Klebsiella. Highly active, gram negative, highly active, first generation. So first generation is highly active against gram positive, highly active against this, right? What happens if the more gram negative adds, like say for example enterococcus, Neisseria, right, or H influenza, which is not there here, only PEK, Pseudomonas E. coli, Klebsiella. So PEK is also here, PEK, Pseudomonas E. coli, Klebsiella, PEK also here. But on top of the PEK, H influenza is added, Klebsiella aerogenes added, enterococcus is added, and Neisseria salmonella is added. So if your blood culture show Neisseria, right, then first generation is not a good choice because it doesn't cover the Neisseria. Second generation is a good choice. second generation, it's good choice, right? So this is the things. This is gram negative. What we are talking about is now gram negative, right? So this is the things. Third generation again extended. So third, fourth, and fifth are extremely extended spectrum. So they all helpful in this, right? Again, fourth thing is MRSA. See, only yes is the septarolin. Am I right or wrong? Yes or no? Tell me at least yes or no.
Yes.
Yes, sir.
All no. See, all no. MRSA, all no. Methicillin resistance, all no, except fifth generation. And in fifth generation drug, as rightly told,
Ceftaroline.
ceftaroline, as per our MCQ. So this is correct answer. Now see the listeria. Now it's listeria. If it comes the listeria, again ceftaroline will help. Ceftaroline, MRSA and ceftaroline, right? No, ceftaroline, no cover, no cover, no cover, no cover. Ceftaroline, yes, that's correct. Excellent. Pseudomonas or Pseudomonas aeruginosa, right? So yes, big yes is this third generation. Big yes is this fourth generation. Fourth generation is cefepime. Cefepime is the fourth generation, right? In cephalosporin, right? So you can use it. And this is ceftriaxone is the third generation. Ceftriaxone. And here ceftaroline. So it does not mean that okay that MRSA covers, listeria covers, meant that also covers Pseudomonas. See here, no. So if you have Pseudomonas and you are using ceftaroline, absolutely no benefit to the patient. It does not cover the Pseudomonas. Is that clear? Yes or no? Tell me at least yes or no.
Yes, sir.
Yes, sir.
Right. So whenever there is a Pseudomonas, I usually, this is the biggest problem in our unit, that is febrile neutropenia. We deal every day. I deal with febrile neutropenia. So patients on chemotherapy, they come with a count of, say for example, 500 WBC count, and they have 103 fever, right? We are worried about gram negative, especially Pseudomonas. So I start randomly with the cefepime, empiric with cefepime. Why? Because it covers Pseudomonas. Is that clear? Yes or no? If my patient has a catheter or central line or PICC line where I am worried about gram positive or MRSA, in that case I start with the vancomycin. Why? Because vancomycin is the best. If vancomycin is sensitive, I use linezolid. Is that clear? Yes or no? So you need to see the context of the patient. All catheter patient high likely or high likelihood of developing the gram positive, right? And all patient with the GI infections, pneumonias and all, right? Or very sick patients, especially in hospitalized patient, obviously they are in hospital. So they have either hospital acquired infections, more resistant gram negative. In that case, we usually use the fourth and fifth generation cephalosporin, or fourth and fifth generation this cefepime or ceftaroline or piperacillin tazobactam, right, for the gram negative, right? So to cover the more box, right? That's it. So this is what the chart is. Did you like this chart? Yes or no? At least tell me yes or no.
Yes, sir.
Yes,
Yes.
sir.
Yes, sir.
Yes,
This is
sir.
It's
not in
very
the
high
book.
yielding.
Yeah, this is not in the books. No books. You cannot find this. This is in the journal. I subscribe many journals, international journals. So from that I am studying, trying to get the answer. So I got this chart. So I thought let me share with you to make the life bit more easy in the practice. Is that clear? Yes or no? Wonderful.
Thank you,
So
sir.
so just remember this chart. Take a picture
Thank
or
you,
later
Thank
sir.
on
you,
you
sir.
can.
Thank you. Thank you.
No problem, sir. Welcome. So now this is the last take home message for this slide. First generation PEK, I told you, PEK means Proteus, E. coli, Klebsiella. Second generation, this PEK is there, but HENS is there. What is HENS? H for H influenza, E means enterococci, N for Neisseria, N Serratia, right? So HENS pack. So PEK is first generation, PEK plus hens is a second, easily understandable, right? And that's it. Cephalosporin, LAM, LAME means 4 drugs, right? Cephalosporin 1 to 4th generation cephalosporin do not act against listeria, do not act against the atypical organism like chlamydia and mycoplasma, MRSA and enterococci. See, MRSA 1 to 4 generation cephalosporin, MRSA does not cover. 5th generation only ceftaroline can cover MRSA. So 1 to 4 generation which does not cover all 4 organisms known as LAM, LAME, LAM. What is LAM? L for listeria, A for atypical organism like chlamydia, M for methicillin resistant staphylococcus or MRS, and E stands for enterococci. So this 4 organism cannot control by 1 to 4. Probably another group of the drug or fifth generation can cover them. That's it. So this is what I conclude my talk on this cephalosporin. So here concluding our answer, this 1, 2, 3, 4, right? And just for your knowledge, I just designed this question in the same way that all this name is, this is first generation, just for your knowledge. This is second generation, this is
Second,
third
third,
generation, this is
fourth,
fourth, and this is
and
fifth.
fifth.
This is how I formatted these questions myself, right? So this is what the 1 to 4 is not the things. Fifth generation covers the MRSA. Is that clear to everyone? Yes or no?
Yes,
Yes, sir.
Yes.
Wonderful, 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 wonderful. Bear with me, couple of more questions, then we'll pack up. Probably last 3 questions, but all interesting and all high yield, asked recently in exam last 1 month. 34-year-old multigravida present with the prenatal care in the second trimester. She reports a history of substance abuse, but state that she has been clean for last 6 months. With her second pregnancy, she experienced a preterm delivery at 34 weeks of gestation of male neonate who died within the first day of life. At that delivery, the baby was swollen, the skin lesion and the placenta was very large. She was treated with antibiotic, but she cannot remember what they were. On routine prenatal panel with this current pregnancy, she found to have a VDRL positive test. Which of the following is the next step in the management? FTABS. What do you mean by FTABS? FTA means fluorescent treponema pallidum antibody absorption test, that is FTABS. Intramuscular penicillin, lupus anticoagulant, oral penicillin, or RPR, rapid plasma reagent. What you want to do for this patient? So again, don't be in hurry. I am not in hurry on Sunday as well. So there are three questions you ask yourself. First, you ask yourself, what's the diagnosis? Ask yourself. Then answer. I am not in hurry. This is not the exam. This is learning platform.
Syphilis.
How you investigation?
FTABS.
And also you need to know
Syphilis.
the treatment as well.
FTABS.
Okay, fine.
It is syphilis, FTABS.
Okay, FTABS. So you post your answer in the chat box. So few people are saying FTABS, right? So let's see. Just let them answer everybody, because if this question comes, na, how this gonna ask? Any comment, Dr. Minas? What's your comment?
So the diagnosis is syphilis.
Okay, diagnosis is syphilis. Wonderful. So let's start one by one. So we'll write down the point what the way you describe me. So diagnosis is syphilis. Okay, fine. Now what you want to do? This lady, she found to have positive VDRL test, and she is a pregnant now, 34 weeks, multigravida. Right. So now what's the next step? You are suspecting or you are diagnosing syphilis. So you want to start treatment or you want to further investigate? 2 questions, right? Now this VDRL is positive. Either you go for some confirmatory test or VDRL positive is good enough, or you want to start the treatment because you know now this is syphilis. I want to treat, sir. What do you want to do, Dr. Minas?
Sir, I would prefer to go for the treatment as VDRL is also already positive and she has previous history of child death.
Okay,
So
fine, fair enough. So now let's go to the treatment, right? What treatment you want to give? From this options or without this option? What you gonna start for this patient?
Intramuscular penicillin.
I'm penicillin, and the dose is 2.4 million units.
Okay, intramuscular or intravenous? First of all, you decide intramuscular or intravenous.
I am intramuscular.
I am.
So first is IM or IV. Second thing is what is the dose in this patient?
2.4 million units is a normal dose.
How much
Which
dose?
2.4 million units.
2.4 million units. Right. What? How then? This dose is one dose, or you should repeat at this dose? You
So it's
repeat
a
or you don't
single dose,
repeat?
sir. It's a single dose,
It's
sir.
it's a single dose. Okay, fine. Leave it. So this is single dose. So it is intramuscular. This dose, single dose, right? What kind of syphilis is this, Dr. Minas? How many types of syphilis
Three.
or grade? I mean, how you classify the syphilis? Have you heard of
Three
something
grades.
like
Primary, secondary, latent
Tertiary.
and tertiary.
so primary, secondary,
Secondary,
by
latent,
my,
tertiary.
then my knowledge latent and then tertiary. Is that clear? Primary, secondary, latent and tertiary. Is that clear? Yes or no?
Yes, sir.
Wonderful. What is the definition of primary? What is the definition of secondary? What is the definition of latent and tertiary? Anyone?
So primary syphilis, it's the first stage, which is contagious and it's last about 21 days. In
21
this,
days.
yes, sir.
Okay,
In
so
this, yeah, we get the chancre and lymphadenopathy. Then the
fair enough.
secondary syphilis, sir, it occurs from weeks to months after the primary stage. It is also contagious. And
Weeks to
then,
months.
yes, sir. And then, sir, latent stage, normally there is no symptoms in this stage. And
So
so the,
asymptomatic.
yeah, and for that, it's non-contagious also. And then, sir, and early, sir, it's the latent syphilis. It lasts more than 1 year sometimes. Um, and tertiary, sir, it's the final stage, and it is also not contagious.
And how long? I mean, you can say up to tertiary. How many years it can last tertiary?
So it
Up
can
to 10
last
years.
from years or decades after initial
1
infection.
to 10 years.
1 to 10 years is the correct answer in general. Fine, fair enough. So we understood there are 4 types: primary, secondary, latent, and tertiary. So this is the time frame. Second thing is, what are the investigation in all 4? Investigation of choice in all 4. And fifth and third question is, what are the treatment of primary, secondary, tertiary, and latent?
VDRL test and
Let me
confirmatory FDA ABS test.
Fine, fair enough. So I'll come on this point. This is I have an excellent chart. I love pictures, so I always come up with the easier solution and non-confusing solution. My lecture is full of non-confusion, not confusion. So this is non-confusing slide. Even if I cannot explain, everything is explained in this chart. If I cannot explain, everybody can understand, but still I explain. Primary, time frame of primary is, say for example, up to 4 weeks, just for your knowledge. We have slides back to back, right? In primary, there is a chancre. The most important, the most highly sensitive test, if they ask you in exam, it's a dark field. Most sensitive, dark field. RPR and FTA for everybody. RPR, FTA, RPR, FTA, RPR, FTA. So RPR, FTA is answer for everybody. But if they are asking you the chancre or some penile ulcer of syphilis on the glands of the penis or vagina, what you do most sensitive is dark field. If not available, RPR, FTA, that's it. Okay, fine. But the dark field is here only. No dark field here, no dark field here, just for your knowledge. So it's a clear cut. So you need to remember there are 3 tests, RPR, FTA for everybody. If you don't know anything, RPR, FTA is the answer, right? But for specific primary dark field, right? This is secondary, this is tertiary, that's it, right? So up to 4 weeks. What is the treatment here in primary? Single IM penicillin. Secondary, single IM penicillin, and here IV penicillin. So what the treatment change in primary, secondary, tertiary is? Just the tertiary, after years and years patient present, IM will not work, IV you have to give. That's it. This is what the answer is, right? Primary, mainly the chancre or ulcer on the penis or vagina or vulvovaginal part. Secondary, you can have a skin problem or skin rash or rash. Is there alopecia, means hair loss, condylomata lata, and mucus patch you can see in secondary. This lasts from beyond 4 weeks. So I can say 4 weeks to 8 weeks. This is secondary. And tertiary, beyond 1 to 10 years. So what happens after 8 weeks to 1 year? What happens? That is latent. Is that clear? Yes or no? Anyone? Yes or no?
Yes, yes, sir.
Yes, sir.
Yes, sir.
Wonderful. So up to 4 weeks, 4 to 8 weeks, 8 weeks to up to 1 year, and 1 year to 10 year is a tertiary. That's it. This is latent. Primary, secondary, latent, tertiary. Is that clear? And tertiary usually have two: CNS, central nervous system, and CVS, cardiovascular. So heart and brains are involved usually in a tertiary syphilis, right? So in neurosyphilis, what happens? Tabus dorsalis, paresis, weakness, and Argyll-Robertson pupil. Extremely important, high yield point. Right? In which syphilis the Argyll-Robertson pupil seen? Primary, secondary, latent, or tertiary? Answer is tertiary. Right? And aortitis or inflammation of aorta, so cardiovascular. Right? Here the treatment is IV penicillin. That's it. So this is what the high yield point is, and this is the time frame. Excellent, important chart, as I already told you, but it's none other than revision of this, right? So this is primary up to 4 weeks, 4 to 8 weeks, 8 weeks to 1 year, 1 to 10 year. This is the time frame. By timing syphilis, by future syphilis, painless canker. Extremely important word is a painful is not a syphilis. Painful is not a syphilis. Painless canker at the inoculation site, usually in the glans penis or vaginal part. Secondary is a rash, skin rash, condylomata lata. I told you. Latent is asymptomatic, right? And then cardiovascular involvement and neurological involvement. Treatment I already explained you. IM single dose, IV in a tertiary. That's it. Is that clear to everyone? Yes or no?
Yes, sir.
Yes, sir.
Now, what's the
Yes,
answer for
sir.
this? Again, the question somebody told, right? So, answer here is FTA ABS.
Yes.
Dr. Minas, I think you told the antibiotic, if I am not wrong, right? So, what your main thing? The next step after any positive screening test is the confirmatory test before starting the treatment. Gold standard sentence. FTA ABS is the confirmatory test for syphilis, and once the syphilis is confirmed, give intramuscular penicillin. So here, for the exam point of view, the answer is FTA ABS, because VDRL can be positive in other condition where syphilis is not present. So it could be a false positive for your kind knowledge, right? So your homework is to find out what are the condition in which the VDRL is positive. Your homework. We'll discuss. Write down your homework. This may come in exam. What are the one of them is a syphilis. So is there any other disease where syphilis is not there but VDRL is positive, right? So you find out. Is that clear to everyone? Yes or no? So here screening test VDRL is positive, then you do the FTABS, and what happens if the FTABS is positive? Then you start the treatment. So once the screening test is confirmed, another example for you to better understand. Say for example, you are dealing with some patient with a fever, cough, and weight loss. You found by ELISA, you found the HIV positive patient, by ELISA, right? What's your what you do? You start treatment or you do confirmatory test for this patient? So you do confirmatory test by Western blot. The name of the test is Western blot. Once the Western blot is positive, start the treatment hard, highly active antiretroviral therapy. That's it. This is how you have to do. So once you have to confirm before starting long treatment, you don't just randomly start on the screening test. Once your screening test, this is applicable to all. So once your screening test is positive, you must do the confirmatory test for this disease, right? And absolutely last questions for today, you guys. This is the picture, no options. Sorry to say, no options, right? Identify the lesion and diagnosis. How you gonna diagnose and treat this patient? Only one line history is a pruritus and particularly at night.
Scabies.
You can post your answer. You can post your answer.
Scabies.
Scabies. Okay, let's see. What point favors scabies? What is something special in this picture? Everybody has a one answer, scabies.
So interferential space pruritus in that area.
Okay. Particularly at night, right?
Particularly
Wonderful.
at night and at the maculopapular.
Wonderful. That is also there, maculopapular. Wonderful. So what's the treatment? Exact treatment is what? I mean, if you see this picture, you give oral, IV, local, topical. What exactly
So
you give to
tropical
this patient?
permethrin and malathion cream.
Topical permethrin, topical. How much percentage? 1%, 2%, 0.5%, 10%, 20%?
5%.
5%.
5%. Wonderful. So that is specific answer. If
Yes, sir.
the 5% permethrin topical is not available, is there any oral drug which you can use in this patient? Second option, like
Malathion.
vancomycin doesn't work. We use linezolid, no?
Ivermectin.
Ivermectin. Wonderful, wonderful. Ivermectin. Wonderful. That's it. So that is what I want to know. And you all are correct. Scabies is a parasitic infections caused by Sarcoptes scabies. You must know which parasite. Sarcoptes scabies, right? Mite, which is primarily transmitted via direct human to human contact and usually seen in the poor hygiene, crowded areas. The female scabies might borrow superficial skin layer, causing severe pruritus, particularly at night. See, interesting. And primary lesion commonly include erythematous papules, vesicles, or burrows in the web of the finger. And treatment of scabies or anti-scabies or scabicidal agent is permethrin 5%, right? So that's it, and this is all the detailed treatment. So first line treatment, as I told you, first line treatment of this scabies is as you all rightly said, I mean, there is no confusion and there is no discussions as well because you all answered well. Permethrin 5%, and if it is not there, then you can use also oral ivermectin or Flavel. Then there are lots of linden is also one of the drug. 1% lotion can be used, and sulfur 5 to 10% for adult and children can be also used as a treatment choice. So once again, thank you very much all for your kind attentions and presence on the lectures. I would be very glad, and I mean, you listen me. Thank you very much. Before I end up the class, I would like to have very quick feedback from the audience. How did you enjoy it or learn something new today's class? Quick
So
feedback.
one question, sir.
Yes, please.
So in scabies, GABA benzene, what is the function, like how it works?
Usually, they usually works when there is a sarcoptes scabies or ovas, right? They usually directly ovicidal effect, what I know, right? And it helps to prevent the replication of this all organisms or parasite. This is how most of the anti-scabicidal drug works, right? But that's fine. I mean, if you don't go much in detail, you this is all high yield pertaining to the exam. I have a lot to speak on this each and every topic, but I'm just concentrating on the what high yield they ask in the exam, right? Otherwise, I can take half the day on hyperinduced thrombocytopenia as a hematologist. But what important point of view you need to understand, I try to make my things.
Okay, sir. Thank you so much.
Fair enough. Any comment? Any comment? Very quickly, any comment?
Thank you so much, sir.
Thank you so much, sir.
Thank you,
Sir,
sir.
the
No, no,
HIT
comment.
topic
Not
was very new to me.
not the thank you. I want the comment. How did you enjoy it or learn? What's the new for
Sir,
you?
we
You never
enjoyed
heard
a
of it.
lot.
I enjoyed every time,
HIT,
sir. Every time,
HIT
every time.
topic was a
We
very new
enjoyed a
topic for
lot,
me,
sir.
sir.
It's knowledgeable.
Wonderful. No problem.
And
Anyone
thank you
else?
for sharing the new slides, which you always uh, work hard to make the new slides or the different from USMLE, the book which we have. So we get to know the extra knowledge. Thank you so much for that.
Fair enough. Any comment, Dr. Minas?
It was very informative, sir. Thank you so much.
Wonderful, wonderful, wonderful. So you just all read the things and you read all the things, topics, all high yield. I try my level best. So we'll see you again with the next lecture and absolutely next Sunday. Thank you very
Thank
much
you,
and
sir.
enjoy your
Thank
Sunday.
you.
Thank you, sir. Have a
Thank you,
good day.
Danish.
Thank you so much.
Thank you. Thank you very much. Thank you. Take care. Thank you very much.